very good morning to everyone. Thanks for joining us for today. I feel honored to those who are going to celebrate Chinese New Year. I would like to wish you in advance Happy Chinese New Year, good health, and wealthy. So today we have Dr. Ken Chow from the Department of Psychological Medicine. He's going to share with us something that we seldom touch on it. We are just focusing on westernized way of coping. For most of us, we learn about problem-focused coping, emotional-focused coping. But for us, what we call Easternized or Malaysianized, they are another way of coping, which we call it a religious coping. So today, Ken Chow will share with us one of his study focusing on this aspect in applying religious coping and mental health. So the floor is yours.
A very good morning, everyone. I'm Dr. Ken. My full name is Chow Ken, but people call me Ken actually. So I'm from the Child and Adolescent Unit from the Psychiatry Department, or I call it Psychological Medicine Department in the UMHealth itself. Thank you, Prof, for the kind introduction. And again, thank you everyone for attending the talk today. And this is the second episode, I think. Yeah, and again, Happy Chinese New Year in advance and Happy holiday in advance. Okay, so I think this is quite a rare topic to discuss on. I think even for the psychiatry fraternity, religious coping. Yeah, but I choose to discuss this topic because I think it's very relevant to us. In Malaysia, is a multiracial and multi-religious country, so it is very crucial for us to know what is the relationship between religion and mental health. How does it help us, or whether how can it bring us through the challenges in our life? How can it help us to thrive through these challenges? I did a very short study 2 years ago regarding religious coping and its relationship with depression and anxiety among our own healthcare workers in the UMC itself during the first year itself of the COVID pandemic. So why the healthcare worker? Healthcare workers are prone to mental illness, such as PTSD. If we are not familiar with the term of PTSD, it's post-traumatic stress disorder. It's a form of mental illness whereby one can develop a range of symptoms such as anxiety, depression, and intrusive thoughts, symptoms of recurrent reactivation of the traumatic scene after a severe stressor such as death of the loved ones or severe illness, especially relevant to COVID now. And also they are prone to depression and anxiety, especially during the difficult times such as COVID, or especially the first year when very little is known about the COVID pandemic. That time there was no vaccine and the information about the virus is very little. So everybody is having a fear towards the unknown entity of this virus. So everybody is busy isolating themselves and treating the needed one. So the risk factor itself could be from the social isolation. And for the healthcare worker, especially the frontliners, they have this fear of infecting the family members. They also kind of have a lack of support also. All this actually could be the risk factors leading to healthcare workers to have a higher risk of depression and anxiety. So I conducted this study on 2020 to 2021 within the first year itself of the pandemic. It's a cross-sectional study, 200 healthcare workers, mainly is from the emergency, anesthesia, and also the internal medicine department, whereby they have to be the frontliners facing the COVID patients. Yeah. So I think two skills. One is the anxiety and depressive skills, very popular to be used in the hospital, well validated and reliable. The other one is less famous. It's a BR group skill. It's a brief religious coping skill in Malay version. It's used to assess how well one utilizing religious coping to deal with the challenges in the life. So what we get from my study from the 200 healthcare workers, the mean score for the anxiety and depression actually is around 6.6 and 5 itself. The cutoff point to say the one is having depression and anxiety is above 8. So you can see our scores actually is lower than the minimum score to say they are depressed, meaning most of them, they are not depressed or anxious. It's less than 8. But why so? Why the lower scores? And even compared with the international study during the COVID pandemic itself, from the CLY study et al. From China, and also Smith et al. Study from Brazil, our scores are also relatively lower for the depressive score. So we were thinking, what were the postulations that our score could be higher, lower? Are our healthcare workers more resilient, or are they suffering less from the stress, or are they facing less COVID patients? Not really. So we got a conclusion that highly possible is from the adoption of religious coping. Religious coping, from the scale itself, we can divide it into positive and negative. Just this brief introduction regarding the scales. Yeah. So positive, meaning these are the few examples, these are in the scale, meaning they look for a stronger connection with the God. They seek love and care and help from the God, and they put the actions together with the God. And they see the challenges, such as a COVID situation, as a chance to strengthen themselves. Yeah. They ask for forgiveness rather than punishment. They focus on religion to stop worrying about their problems. So this is the positive part. So let's say from the negative part, from the skills, they will be thinking whether God has abandoned them, and they felt the challenges they face will be the punishment from the God. Yeah. And they question the love and care from the God, and they thinking the church whether they abandoned them or not. And they were starting to believe that whether the devil have making this happen, and question the power of the God. And this skill, when it's divided into positive and negative religious coping, we show that our correlation with the anxiety and depression skill is very correlated, meaning higher positive religious skill has a positive impact on the mental health, meaning it gives rise to a lower depressive and anxiety scores. And it's quite significant, it's less than 0.01. And higher negative religious coping, meaning there's more doubt and question to the God's power, and there's higher depressive and anxiety score. So this is likely why our healthcare workers could be having lower anxiety and depression rates than the other countries itself, and lower than the mean score itself. Even adjusted for other correlates, because one might ask whether you have adjusted for other variables, other confounding factors or not. We adjusted for a few factors using the general linear model, linear regression, and anxiety and depression are still significantly correlated with positive and negative religious coping, respectively. Whereby positive religious coping have a positive impact, negative religious coping have a negative impact on mental health. So we got a conclusion: religious coping, especially the positive one, could be a protective factor in the mental health in reducing anxiety and depression, especially among the healthcare workers during these challenging times. Yeah. But how to do it and how to apply it to our daily practice, right? Because always when we do research, we want to look back and see how do we use it, not just to talk on paper or cakap kosong. Yeah. Pargaman et al., the one who developed this skill during 2000, and he developed a series of studies to test this skill. He found that 21 measures to use this skill, but 21 measures is very difficult to remember, but 5 key domains will be easier to remember. He find that redefining the stressor using the God's power will be a manner, meaning they see the stressor as a challenge from the God to make them stronger. So this is one way to do it. Another one is to give up the control to the God, meaning when you can't control certain things, you leave it up to the God. You do the things that only you can control. The third is comfort and proximity to the God, meaning they shift focus to religious activity so that they can have a form of distraction and coping skill. And in turn, they can gain support and connection with the other, let's say, church or mosque members. This is very true, because I have a lot of patients, actually, they gain support from their religious activities. Not just they can actually, as a coping skill, they gain the support from there too. The fourth one is life transformation, meaning on top of so-called work-life balance, because most of the time we are talking about work, family, and ourselves, and how to balance out between work life. And when do we talk about religion and spirituality, right? So this could be something to look into besides work life, something to look into spiritually and religiously to explore upon. So this is the 5 domains that Parliament has suggested to use in all. So again, understanding the concept is not equal to realizing how to use it. So I would like to use this in terms of my practical skills also. I find that use it in the positive and negative still is the most efficient way, meaning we figure out what is the religious coping of that patient, whether they are adopting more positive or negative. So these are the few examples more to the negative coping. Because I'm working in the child and adolescent unit, I find a number of parents actually they tend to ask the child to pray more and do not forget more God, and they start to use the ways of threaten, not so nice to say. They will say God will punish you if you do not do so and so. It is because you didn't pray enough, and hence this happened to you. Imagine how will the child feel when they hear this kind of threat or instruction. So this will indirectly encourage more negative religious coping. So what is the plausible right way to do it while incorporating the principles from Parliament? Could be you explore what is the religious coping first and try to modify it to positive religious coping. Advise them to get closer to God, not just ask them to pray more, and believe that God will help you and love you despite the challenges surrounding you, and believe that the current difficulties are a way from the God to make you stronger in the future, and ask for forgiveness from the God rather than a form of punishment. Yeah. So these are the few practical ways we can advise our peer or the child or our family members, and not just asking them to pray more. And even adults, I have a lot of patients asking their friends to pray more, but what are they praying for? What is inside the thoughts? What are the feelings when praying? So these are the few points to take upon. And if we can use it, religious could be a very meaningful way for us to strive through the ups and downs in life. Yeah. Thank you very much.
Thank you, Dr. Ken, for the concise and informative, insightful talk. So I think Dr. Ken have bring us a new idea how to help our patient to manage their stress, or our healthcare worker to manage their burnout during their journey of their career. So all the while we talk about religious, we always think about operationalized component or the institutionalized activity. So I think Dr. Ken has shared with us the internal religious coping is very important. The direction of your internal religious coping. So I think now is open to the floor. If there's any questions or doubt about what Dr. Ken have shared with us today, is there any burning questions?
I saw a question in the chat box. Sarah said, yeah, interesting. But did you actually, yeah, the scores were lower in the chat box. Q&A.
Yeah. Q&A. Oh, not the chat box, sorry. Interesting, but do you actually prove that the score were lower in our healthcare worker because of religious coping skill? Okay. Dr. Ken?
This is a very good question. Because of religious coping, it is only one of the reasons. If you're interested, you can look at my papers. There are a list of other factors as well, whereby female, the occupation nurses, they have lower rates of anxiety and depression also. There are other factors to be considered. So, for example, the gender, the occupation, shift work, for example, you can look at my paper and see how. So this is only one of the factor, because if I bring it in, it'll be more than 30 minutes. Yeah. So, okay.
But just bear with us. I also also did a number
Sorry.
of study and religious coping. There is no such thing. Just to share with everyone, don't get the wrong idea. Is there a cutoff point below how much score is considered low or high? We just managed to establish there is a correlationship. I think for religious coping, we can't kind of difficult to decide where is considered low, where is considered high. So we always use back the population of our study to determine the scoring. So next question from Dr.
There's
David.
no cutoff point.
No cutoff on this. Another question from Dr. David. Sometimes we might feel reluctant to address religious coping because we don't consider ourselves ustash or adri. So I can the answer. Yeah.
Oh, yes. Well, I think this is a very right question. Okay. But it's not to ask us to be doing it towards the extent of ustads of adri, etc. But at least we can explore in a very brief manner whether the religious coping of the patient is helping them or is it not really helping them. So we can probably then refer to the right person, because I believe we do have ustads in the hospital side, right, Prof?
Yeah.
Yeah. So at least we can choose whether we want to refer or not. This can let us to have a brief idea. Beside to advise briefly, then we can ask to screen also, right?
Yeah. I think I agree with Dr. David. Not all coping is applicable to everyone. So we are just introducing another idea or aspect that we can explore in helping our client, or patient, or our colleague. But definitely certain people, as Dr. David said, they just don't believe it. They don't want to touch on this aspect. We cannot forcefully ask people to apply it, but just another option. Okay, next question from Dr. Sajara Tunisa. So the question is, how do you differentiate between religiosity and spirituality? Okay, I will leave it to Dr. Ken. It's a big topic. I think there are many articles discuss about this.
This is a big topic, correct. The reason I link spirituality and religiosity in my words just now, because I believe many studies have been trying to differentiate and equate them. And a lot of debates have been going on as well, whether they are the same or they are different. There is actually a few studies trying to link them together. And in fact, they're trying to link religious coping with spirituality. And actually, there are a few studies among Pargamen themselves. They find it to be equated as well. But in locally, Malaysia-wise, there's no exact study to try and differentiate and trying to link them together. Yeah. So, but for me, myself, I think religious-wise, I think there is a religion. There is a ancient text and backup to, and a set of rules and text to refer to guide us towards the larger entity, the bigger entity above us, which is the God. But for spirituality, it doesn't mean we have a larger identity or the upper entity above us. It's more towards the self-exploration rather than the relationship with the clear identity with the God itself. So I would say spirituality is more to exploration about the internal and about the meaning in life and also the past and the future, rather than the connection with the God itself, a direct connection with the God itself. But if you want to look it up upon the literature a lot, but for me, this is my experience and answer. So if how to use it practically, I think for spirituality, I think is more efficient in my experience, to use it for those without religion. At least, if for religion, then use it on the ones with clear religion background and they are practicing religion. So that will be the better ideas or tips to be used in the our daily practice. Okay, does that answer your question?
I think it's quite clear, Dr. David, Dr. Ken. So there are a lot of overlapping, they are not the same. Because shortage of time, let's take another questions before we move to another talk today from Prof. Guan Hong. Was the general health of those who practice religious coping better than the others? Any evidence? Dr. Chong?
General health of those of those who practice religious coping better than the others. Oh, okay, that's an interesting one. So far, I haven't read about it. Clearly speaking, I haven't looked into that. But in Malaysia, mental health wise, yes, there are two studies who did whereby our psychiatrists have did study on psychiatric patients who practice religious coping have actually more stable and improved mental health than the others. But for general health wise, I haven't come across yet as a good idea to do it. Yeah. Okay.
Yeah. I don't think we have any studies so far. I think
Yeah.
it really gives us a new idea
Yeah.
what to do in the future. So far, religious coping, since we developed the skill, not develop, since we translated the skill, we have used it for nurses, we have used it for cancer patient, we have tried it on healthcare worker and medical student. But mostly we study about the association of religious coping with anxiety, depression, and stress level. We haven't really examined the general health status. So thanks, Prof. Ng Kwan Hong. So we may explore this aspect in the future study.